Transposition of great arteries. Transposition of the great arteries is a congenital cardiac anomaly characterized by ventricular arterial discordance with origin of the aorta from morphologically right ventricle and the pulmonary artery from the morphologically left ventricle. It is most common cause of the cyanotic congenital cardiac disease in neonates at around 15 to 20% and represents 3 to 5% of all congenital disease. There are two types of transposition, TGA, the more common form, and the dextrolooping of the ventricles, which lead to atrioventricular concordance. RA drains into RV, which drains into aorta, and the LA drains into LV, which drains into pulmonary artery. LTGA, congenitally corrected TGA, occurs with the levo-looping of the ventricles, which leads to both atrioventricular and ventricular atrial discordance, in which the morphological ventricles are switched to RA, emptying into LV via the mitral valve, which drains into the pulmonary artery into the lungs. The LA empties into RV with tricuspid valve and returns to systemic circulation via aorta. LTGA is often referred to as physiologically corrected due to systemic deoxygenation. Deoxygenated venous blood returns to the pulmonary circulation, and oxygenated pulmonary venous blood returns to the systemic circulation. Morphology of DTGA is discussed, and the DTGA, the aorta is generally anterior and to the right of the pulmonary artery and arises from the RV. It causes hypothesized to be due to abnormal growth and development of bilateral subarterial conus leading to resorption of the pulmonary conus and irregular migration of posteriorly with association of mitral valve and LV. The unabsorbed subaortic conus remains anterior in connection to the tricuspid valve and RV. A VSD is present in about 50% of the cases and is commonly conoventricular, although any type can be present. Commonly, a PFO is present in the secundum ASD due to 15 to 20% of the cases. Anatomical LVOT obstruction is more likely to occur in TGA with VSD, while functional LVOT obstruction from bulging of the interventricular septum into LVOT from a pressurized RV into the TGA with an intact septum. Roughly 5% of the patient will have some form of LVOT obstruction without a VSD. In the DTGA, the coronary arteries typically arises from the aortic sinuses that face the pulmonary trunk, allowing for the ease of the transfer. During the arterial switch operation, the coronary sinuses are numbered according to the Leiden convention, viewed from the non-facing aortic sinus looking towards the pulmonary trunk, and the aortic sinus into the right sinus 1 and sinus 2. The most common configuration is 1LCX2R, the left main arising from the anterior and leftward facing sinus, and the right RC arising from the posterior and rightward facing sinus. Rarely, they may arise from non-facing sinuses, making a coronary transfer more challenging during the arterial switch operation. In 60 to 65% of the cases, the coronary arteries arise from two different ostia, but the remaining third of the coronary anatomy may be abnormal, and this include LCX arising from RCA, a single RCA and a single LCA, or inadvertent origin of the coronaries. Additionally, the courses of the coronary arteries may vary. Unusual epicardial course, multiple coronary ostia loop around the great vessels, pass between the great vessels, or have been intramural course. The systemic and pulmonary circulation of TGA are parallel, and for survival, mixing must occur at the arterial level, usually a PFO or a secundum ASD. Ventricular level VSD or the patent ductus arteriosus PDA, the TGA with other abnormalities can be referred to as complex, whereas the simple TGA is without other abnormalities could be associated. There are three variants of TGA: TGA with intact ventricular septum, 50%. The neonates with this type develop cyanosis after birth. Mixing of the systemic and pulmonary circulation needs to occur at the arterial level and most commonly via PFO or secondum ASD. In 15 to 20% of the cases, a restrictive ASD usually arises from balloon atrial septostomy. A PDA is helpful in some cases by increasing the atriopulmonary flow and forcing more shunting at the arterial level. As the LV ejects into the pulmonary circulation, whose resistance progressively decreases over time, like 4 to 6 weeks, the LV will have insufficient mass and contractility to support the systemic circulation is switched, and this may require retaining of the LV to gain develop LV mass and force with a pulmonary band, and in some cases rather than retaining the atrial switch, leaving the RV and systemic ventricle might be considered. TGA with VSD. The TGA with VSD leads to effective mixing of pulmonary systemic circulation with LV exposed to adequate pressure, thus retaining the ability to sustain systemic circulation. If switched later, a VSD is most commonly conoventricular and unrestricted will lead to pulmonary circulation, causing the heart failure. The cyanosis is generally mild. Pulmonary overcirculation for unclear reasons in the TGA can result in the early development of irreversible pulmonary vascular occlusive disease. TGA with VSD and pulmonary stenosis. This VSD allows the adequate mixing of the circulations. The pulmonary stenosis rarely occurs at the valvular level and restricts the pulmonary overcirculation and thus prevent the development of pulmonary vascular disease. The LV remains capable of supporting the systemic circulation due to pressure load from both VSD and PS. However, excessive pulmonary obstruction can cause hypoxemia, leading to a clinical presentation similar to TOF. An arterial switch operation may not be possible if the pulmonary valvular or subvalvular stenosis is significant. The DTGA is one of the most difficult congenital heart disease to diagnose in the fetal ultrasound due to absence of the ventricular discrepancy. Chest X-ray may show egg-shaped heart with a narrow superior margin, and pulmonary marking may be increased, especially in TGA with VSD. ECG may show the evidence of the right of biventricular enlargement. Echocardiography is a diagnostic modality of choice. It demonstrates posteriorly based grade artery arising from morphologically left ventricle from the right and the left PA, and the anteriorly based aorta arising from the morphologically RV. Besides this, echocardiogram also allows the assessment of the size of the great vessels, origin of the coronary ostia size, location of VSD, and presence of LVOT obstruction, ASD or PDA. The fetal diagnosis of TGA varies greatly from 20 to 40% depending on the institutional experience. Angiography is seldom required to make the diagnosis, although remains the gold standard for elucidating coronary artery courses and origin. Additionally, the most crucial role of the cardiac catheterization remains the balloon arterial septostomy. These are the relationship of the great arteries, and the initial management consists of administering PGE to maintain the PDA, balloon arterial septostomy to allow the free atrial mixing. In the case of restrictive atrial shunt, the PGE may then be stopped to allow the PDA, and before balloon septostomy became commonplace, a Blalock-Hellon procedure could be performed to surgically create off-pump ASD and a right thoracotomy. Once the infant is stabilized and corrective surgery is optimally performed in the first week of life, the PA banding may be required as a temporary palliative procedure in the sick premature neonates with TGA and VSD to restrict pulmonary circulation before a definitive repair is done. Similarly, the PA banding is used in the patient with delayed diagnosis of the TGA and the intact septum and the conditioned LV in order to retain the LV, and the timing of the surgery is typically performed within the first 2 weeks of life. The definitive surgical management involves a rerouting of the systemic venous return to the pulmonary circulation and pulmonary venous return to the systemic circulation, and this can be done at the arterial or the greater arterial level. The routing at the arterial level, however, does not correct the underlying ventricular atrial discordance and the aorta rising from the right ventricle and the pulmonary artery from the left ventricle. This places RV in the systemic position. The use of the natal atrial tissue and the mustard using the autologous pericardium atrial switch operations and the atrial baffle procedures which direct the systemic venous return to the mitral valve and the pulmonary venous return to the tricuspid valve. Though there is a physiological correction and there is no anatomical correction. The RV and tricuspid valve are placed in the systemic position, potentially leading to the a late ventricular dysfunction and the atrial arrhythmias and the heart failure, again due to the RV serving as a pump for the systemic circulation. Additionally, two-thirds of the patient develop intractable supraventricular arrhythmias from the extensive atrial suture line and may cause death, and the patient can develop obstruction or leaks in the atrial baffle, and the atrial switch is still performed in some centers with the TGA with an unfavorable coronary artery anatomy or the delayed diagnosis of the TGA with intact septum leading to this conditioned LV incapable of supporting the systemic circulation if switched by the arterial switch operation. Today, the preferred procedure of the arterial switch operation, it leads by both anatomical and physiological correction. The procedure involves the division of both the great vessels above the sinotubular junction and harvesting the coronary buttons from the aorta and transfer to the adjacent facing sinuses of the pulmonary root to create the neonatal root. The new pulmonary root is reconstructed after the coronary arteries have been harvested by using the autologous pericardium, and the pulmonary bifurcation is brought anterior to the descending aorta after extensive mobilization of the PAs up to the first order branches in order to decrease the tension of the anastomosis between the new pulmonary root and the pulmonary artery bifurcation and prevent PA compression by the aorta. The new aortic root is anastomosed to the ascending aorta and to the new pulmonary root for the pulmonary trunk. The VSD is closed via the right atrium, followed by the closure of the ASD. Early complications of atrial switch operations are generally related to coronary ischemia from the inadequate malposition of the coronary transfer, but can include the aortic and pulmonary anastomosis, and the issues are rarely valvular injury, deformation, late complications, including the RVOT obstruction. The most common cause of reoperation is coronary stenosis and the neo-aortic root dilation with insufficiency. The TGA with intact septum, the arterial switch operation, is performed as a neonate before LV losses conditioning. If the repair is delayed beyond the newborn period of 1 to 2 months, the option would include the atrial switch and a two-stage operation by pulmonary banding to train the LV, followed by the arterial switch operation may be required. Arterial switch operation has been described up to 6 months of age, utilizing temporary LV mechanical assistance to transition of the LV systemic pressures and output capability. The TGA with VSD arterial switch operation is preferable in the neonatal period, though it can be performed later if performed by the vascular disease. TGA with VSD and pulmonary stenosis, these patients require a complex operation as the switch may lead to LVOT obstruction. These procedures are performed beyond the neonatal period, generally up to 6 months of the given age. Complexity of the operation. In term, the aortopulmonary shunt may be required to maintain the adequate pulmonary blood flow, and the operation could be performed, including the Rastelli procedures. This involved creating the infracardiac baffle between the LV across the VSD to the aorta and reconstruction of the LVOT with the valve conduit in the distal PA. A REF procedure, instead of using the pulmonary conduit as Rastelli procedure, the pulmonary bifurcation is directly anastomosed to the RV, and the additional subvalvular muscular resection can be performed in order to prevent the obstruction of the baffle. This procedure avoids the need for the conduit revision to match the somatic growth, but can leave pulmonary insufficiency. Necoda procedure. As a part of this procedure, the aortic root with the attached coronaries is translocated posteriorly to the LVOT where the hypoplastic pulmonary valve was. The VSD is repaired with a patch and RVOT is reconstructed with a prosthetic material around the aortic root. In the patient who do not receive the treatment, most likely die within first years of life, and approximately 30% of untreated patients will die in first week of life, and the 90% with the first year of life. Subaortic VSD with pulmonary stenosis, the post-division, the pulmonary vascular obstructive disease, the oxygenated blood from the LV is directed to the aorta and can lead to Eisenmenger syndrome. So doubly committed and non-committed VSD is a mixture of the oxygenated blood and desaturated blood directed to both outflow tracts with mild cyanosis and increased pulmonary blood flow, and there would be a ventricular septal defect. Thank you.